good afternoon, or good morning, or good evening, wherever you watching us or listening to us. So welcome everybody to a streaming event and to a live surgical event, which is very honorable to have you with us. And it's very exciting for us to try this as a new platform to get you all inside our OR to see and to share with you some techniques, some new lenses and whatever. And during the next years, you see that we will go on with this platform in communicating with you. Today we are not only focusing on the MIOL itself, because when I talk about the problems of the MIOL, I also have to talk about the solution. And the solution is to deal with the whole surgical concept of MIOL surgery. This is, of course, the MIOL. This is the surgery. These are the instruments. This is the surgical technique and the way how to remove the lens. All this will be covered to some extent today. So I would like to give you a short overview what we are dealing with today. So we are not talking about a standard MIOL today. We are talking about a system called Liberty2. This is a very innovative platform for multifocality because it consists of two IOLs. If you're looking to the presbyopic cataract and presbyopic lens exchange patients, we have an increasing request of the patients and a higher refractive demand than it was 10 years ago. We have an increasing number of patients after LASIK or PRK, which also includes that there are higher demands for the refractive errors after surgery. We have an increasing number of refractive IOLs for presbyopic correction on the market, but we have still no simulation of the vision through a multifocal optic. For those who are not familiar with this optic, maybe a little bit astonishing, because as you see here on the slide, you have a kind of rectangular optic, the AddOn IOL, specially designed for the implantation in the ciliary sulcus. And as you can see here, this is a platform for refractive solutions, so spheric plus or minus, for toric solutions, and this is the topic of today, inside the so-called Liberty system, a basic IOL inside the capsular bag and a progressive trifocal lens with different additions in the ciliary sulcus. Today we're doing an implantation of an AddOn multifocal IOL with a +3 addition, but you have the free choice to use 1.75 or 2.25 as well. When I tell you that the diffractive array of the IOL is only a 6-step array, it's astonishing to have a trifocal optic result through this only 6-step diffractive array. This is because of the so-called EPS technology, the elevated phase shift, which allows over a constructive interference in the middle the creation of an intermediate peak. So you have a trifocal constant solution and vision from near over intermediate to distance only by a 6-step diffractive arrow. This also includes the fact that thereby the creation of side effects is much more lower compared to other lenses. There are other features worth to be mentioned. These 4 haptics makes a perfect sulcus fit. So all the anatomical features we cannot see makes it possible that the haptics adapt perfectly to these anatomical structures, allowing the IOL to center perfectly. It also has a very high rotation stability because also those 4 haptics not only perfectly fits in the sulcus, but keeps the IOL very stable. It's totally avoidable that both optics inside the capsular bag and in the sulcus have any kind of contact towards each other, which means that there are no pseudomembranes or cells which can be grown inside this intermediate space between both optics. And last not least, those square edge design of the IOL makes it impossible to create any kind of iris capture. Our first patient, and I thank you very much for your patience, is a 66-year-old female patient with cortical cataract formation, a visual acuity of 0.3 on both eyes, slightly hyperopic, with, as you can see here, more corneal astigmatism as it should be when we look to the glasses. So we decided to use a toric monofocal IOL as a basic IOL in the endocapsular bag, and a multifocal add-on on top of it. Paracentesis, some licaine inside the A.R.C. to increase the anesthetic effect. A 2.0 millimeter clear corneal incision. Ja. I normally use the needle to do the capsulorhexis. You can use from femto laser, as you know, to forceps, whatever you want. Hydrodissection, hydrodelineation. Kann man bitte die Dings nochmal haben, die torische? Oben könnt ihr draufdrücken. Start. Ja. Start. Confirm. Ja. Jetzt ausschalten, die 2 Punkte. You normally need, there was a question, what size of the capsulorhexis you need. I normally aim for 5 millimeter. Now we try to remove the lens. The system we do so is the Nano Laser from the A.R.C. company, which I prefer in our premium cataract patients throughout the last 6-8 years now. The system totally avoids any amount of thermal or mechanical damage during the process of the removal of the lens. You hear the clicking of the laser. This is, from my point of view, the surgical system with the lowest energy applied in the eye to remove the lens. As I told you, another point to focus on today is, or are the instrument, the disposable instrument. I normally use a modified new hand chopper as a double instrument with the push-pull on the other hand. Removal of the cortex and the left fibers left in the capsular bag. There is a small part here as well. Sie machen das super. Geht's Ihnen gut? Ja. Perfekt. Mir geht's auch gut, gell? Now I use the water jet to clean the capsular bag. Removal of some more fibers. Very good. So now we will do the implantation of the toric IOL. It's a hydrophobic IOL Ist Mittozell drin? A normal 3-piece design. This one is not preloaded because it's 26 diopters with a torus of 2 diopters. It's very easy to implant it. The implantation axis is 94 degrees. After the implantation, normally when I only implant one toric IOL in the capsular bag, I would now remove the whole viscoelastic. Now I will do the same, just to have the bag clean with Helon. And now I fill the A.C up again with Provisc and try to create more space between the iris back face and the capsular bag. So now the eye is prepared for the multifocal add-on IOL, which is also injected through a cartridge of 2 millimeters. Damit's machen wir es gleich nochmal rein. You can see here that I'm trying to buckle up this IOL. This is because normally it's easier to unfold the IOL by means of this properly in the A.C, but you can also do it the other way around. You have to be very careful not to incarcerate the fine haptics inside this cartridge. You always have to check this prior to the implantation. I always use 2 instruments for the implantation, the push-pull and of course my injection system. This is on the one hand to stabilize the eye. The other reason you probably see now, because I go with my second instrument underneath the optic to lead the unfolding process inside the A.C to avoid that the optics primarily go inside or underneath the to avoid that the haptics go underneath. Now you see our first haptic is still underneath the iris. Now the second one can be very, very gently and easily pushed underneath. Now you have to tell the patient that probably she realizes some, not pain, but the patient can probably feel it. So now the IOL is in the ciliary sulcus. It's very important to rotate it a bit. You saw that I rotated it during the implantation process because this ensures that the haptics are properly unfolded. Now we have to check that the implantation of the add-on didn't interfere with the axis of the underlying toric IOL, which is hardly the case. Now I'm satisfied. There will be a final check. Probably I will rotate the lens as well. Das ist ein kleiner Druck nochmal. And it's also important to remove the viscoelastic between both lenses. Wasser? Oh, ich hab. So. Okay. Ganz locker. Und zu mir mal schauen, bitte hier hoch. So, here we are. That's it. Sehr gut. War das schlimm? Ja. Ging alles super, haben Sie gesagt, ne?
Good afternoon, Professor Sauder. I'd like to thank you for inviting us into your OR, also your staff for hosting us during this
You're
live surgery.
very welcome. This is very welcome. I would like to introduce Peter Mattei, who goes with me through this day and surgical event.
I have a question. You're left-handed, correct?
Yes.
Okay. Why do you like this piggyback system?
I don't think I was the first to implant the AddOn IOL, but I think among the first 10 who did it, and it was 10 years ago. But this Liberty system is called Liberty, and I like the name because you have the liberty to adapt your lens system and to the visual and the refractive needs of the patient. For example, if you have patients unsatisfied with the visual acuity, or patients who say, okay, you told me the side effects of the multifocality, but I cannot deal with it. It's very easy to explant this lens. We don't want to explant the lens, but it's very easy to do so. Where we all know it's much more difficult to explant endocapsular implanted lens after, let's say, half a year or so. The other thing is, if you have if there's any need to adapt this lens, let's say the astigmatic change or whatever, it's much more easier to adapt in this kind of lens system. The lens to the new situation, when all other cases after several months or years you cannot change anything.
So you feel that this lens system gives you more flexibility with younger patients?
It gives me more flexibility with younger patients. It gives me more flexibility to adapt a system. It gives me, I'm convinced that the visual acuity to two lens systems is better. You have less negative photopsia, you have less glare. Yeah, the patients are very happy with this. Good.
So I would think that if you're doing both eyes the same day, you're maximizing your wow effect, especially if you're using multifocal lenses.
Absolutely. We had a patient in this morning also doing a Liberty system. The patient was +8 with a corneal astigmatism of -4, and this was an absolute wow effect. The patient can walk outside this clinic without glasses and can see. Yeah, it's a certain wow effect. Absolutely. And the nano laser, the surgical system, also fit in this procedure and in this strategy because it's less traumatic to the eye, which is very important if you do both eye surgery.
What do you mean by less traumatic?
Less traumatic means small incision, no thermal gradient, no mechanical shockwave-like effect. Absolutely less energy given inside the eye if compared to phaco. This is less traumatic.
I've noticed that this eye was performed with under 500 microjoules of energy.
Yes.
So
yes.
That is almost minimal amount of energy.
Normally in a let's say LOX N2 up to N3, you normally end up in a total energy given in the eye between 500 millijoules to 1 millijoule to 1 joule.
Okay, and that's the energy indicated by the machine, the amount of energy actually emitted in the eye?
No, this is the energy given in the eye. The energy measured by the machine is higher, 8 folds, but it's measured inside the tube of the nano laser. Then the energy given in the eye is 8 folds lower, so you end up between 500 microjoules and, yeah. Yes, a very good question. Thank you for that, because if there's a need, and I see in this question that obviously in all parts around the world there might be some need. I see the need if the patient after half a year after 1 year is still complaining about the side effect, tells me that this is not the way I want to see and I want to live, and I want to get rid of this and accept the glasses for reading, then I explant it and then I cut the lens. You can fold it back as well, but I prefer, because of better scissors and smaller forceps, we have a special setting for the explantation. I prefer to cut it through and explant the lenses, the half of the lens.
Is there a need to do iridotomy?
Yeah, also very good questions. I probably forgot that. No, from my point of view, there is no way to have a pupillary block formation, even in the add-on system. I never ever did a peripheral iridectomy or iridotomy, and I never regretted it. Today, we wanted to have a look to the Liberty square system, and hopefully I was able to show you what this means. But why putting 2 IOLs instead of 1 inside the eye? I think we have more options for the patient and surgeons with a better adaptation to the refractive situation. You can combine 2 lens systems inside the eye. Let's make an example. We had patients, stable keratoconus, which was had a very stable refractive error. So we used not a multifocal add-on, but a toric add-on to correct the astigmatic error. It's obvious very much better to do it in this way, because when the curvature and the meridians of the keratoconus eye differs and changes, it's very easy to adapt the add-on lens to the new situation. And it's the same in the multifocal patient. You have more safety and a better refractive adaptation to the patients. Moreover, as you can see in the next graph, the question why 2 lenses probably are better, it's not only because you have less disturbing side effects, but having 2 optical surfaces inside the eye makes a more natural imitation of the dimensions of the natural lens. So if you have a basis IOL, there's a larger distance to the iris aperture. In the 2 lens system, all the pseudophakic situations you create are more closer to the natural lens dimensions. This is a new concept, but this is not a new expertise. First Q got 20 years of add-on experience so far, and it's an internationally still growing market for those systems. There is a special designed lens for sulcus implantation in terms of safety and efficacy in the sulcus. The sulcus fit design makes it very easy to implant the lens with those 4 flexible haptics. There's a big and high rotation stability, and no touch, no cell means that the convex concave optic avoids the immigration of intralenticular cells, and no iris capture occur. Another thing to mention is you don't have big storage problems if you use those combinations of IOLs. If you combine the optical system performances of the Liberty system, you have a sphere you can correct coming from -10 diopters to +45. You can correct the cylinder from 1 diopter up to 11. And with regard to the addition in terms of reading ability in the multifocal IOL, you have the choice between +175, +2.25, and +3. So with 121 single IOLs only, you can individualize a refractive power combination of 3,500 different optic combination, diopter combination, which makes the whole storage problem and the administrative part very easy.
Greetings from Croatia and congratulations.
Thank you very much.
Does it matter?
From where?
IOL is implanted upside down.
Yes, it does matter. You have, I didn't focus on that to be not too complicated. There are two little spots on the side of the AddOn IOL indicating the surface and back face. So you have, there is a side and B side because of two reasons. First of all, you have to align the lens in the convex-concave plane so that a touch of both IOLs can totally be avoided. Okay, there are different ways to manufacture single-use instrument or disposable instrument. The one way is to do more or less the same as you normally do if you do a non-disposable system, but with cheaper materials and let's say less sophisticated manufacturing process. In these cases, you see automated manufacturing technology with a very scalable and high consistency of each of these products. The products are also designed and produced from the first Q company, and as you could see, the double instrument with a chopper and a push-pull on the one side. We have an Utrata forceps, we have forcepses as well. So you have a whole portfolio of disposable instruments. So what you have to do is you have to make a choice if these disposable instruments fit in your planning and doing cataract surgery. We think that this is a very good concept to get rid of all the problems you have in the re-sterilization process, in all the problems with repairs, regulatory aspects, the documentation of all these things. On the one hand, on the other hand, you have always new instruments. There is no defect instrument or need for repair or whatever. You have 100% safety to the guaranteed sterility. You have an excellent performance with these new instruments. It's not always in every setting, but in our setting is we have more cases through the single use and less cost. So I would like to introduce you now the second patient. We also will perform a bilateral refractive lens exchange with the Liberty system. The patient has plus 2.75 and plus 2.5. We have, it's just on the border, it's on the right eye, it's round about 0.75, and this is normally where my margin is to use a toric IOL in a multifocal patient or not. The left eye is lower, so I decided to use a monofocal IOL as a basis lens and the multifocal add-on on top of it. There was one question, thank you for that, about if I would do an implantation of a multifocal add-on IOL in a patient already underwent a YAG laser capsulotomy. I would answer these questions with an absolute yes. If you have a stable intraocular lens, let's say 10 years after cataract surgery, there's no need to be afraid of an additional implantation.
Do you have any other inclusion-exclusion criteria for this lens system?
Only the depth of the interior chamber, maybe some other pathologies inside the eye. I cannot remember one where this was the case, but no.
So I see you use a Centurion vision system with your CETUS Nano system. Could you tell us about the settings?
So you see that we combine the nano laser with the Centurion, and the fluidics come from the phaco machine. And the Centurion is, yes, let's say a Venturi-like peristaltic system. I don't hope the Icon guys get mad at me when I explain it like this. It is very aggressive in the suction force, and we have a flow of, I think, 50. We'll see it later, and an aspiration force of 600 millimeters of mercury.
And your nanolaser settings?
The nanolaser settings is 6.5 microjoules per pulse.
And firing rate?
Huh?
Firing rate?
The firing rate is up to, let's say, 8 hertz in this setting, because the triggering of the laser pulses is via the vitrectomy port. So what you basically do is you behave like you are doing a vitrectomy with your phaco machine. And those air pulses are transduced into electrical pulses inside the laser. And if you have, let's say, 500 rounds per minute vitrectomy frequency, you will end up in a frequency of 8 hertz of the nanolaser. So you hear the 8 hertz, and you can trigger. Sometimes it's slower, sometimes it's more speedy, and you do this by your foot pedal. So the use of the nanolaser is very self-explaining and very intuitive. You basically perform the surgery with the phaco machine you probably use, you are used to deal with, but it triggers the laser. The side port of the laser, the opening hole, is not rectangular and not parallel to the axis of the tube, but it's angled so that it's very easy to reach nearly every point inside the capsular bag, and this makes the whole situation very safe, because the last thing I would like to do is a capsular rupture. Oh, it's a good thought maybe. If you have a capsular rupture with the nanolaser, you normally have a round hole inside 23.0 inside the posterior capsule, and not a rupture. So it's normally easy to deal with this by enlarging the hole towards a posterior capsular axis. So here the posterior part of the lens is a bit more sticky on the capsule. Again, cleaning the posterior capsule with a water jet, preparing for the implantation of the basic IOL.
Your nanolaser technique seems to be very advanced. Do you find any differences between phaco and the photofragmentation at this stage of your use of this system?
Yeah, when colleagues are visiting us in the OR, I always tell them that my approach to the new technique is not to explain it as another kind of phaco. You have to listen to the interaction between the laser and the tissue, and it is different. It is different. It's not another kind of phaco. We established two kinds of techniques. The one is in the softer cases, as you could see today, the bowling technique, where you circularly move inside the capsular bag to remove the nucleus and then the cortex. The other is a chopping technique, I normally use in, let's say, 95%. But it's different compared to a normal phaco. So now we are at the implantation side for the AddOn IOL. There was a question about the alignment and the way to avoid an upside down implantation. I would like to show you the lens. You see here the 6-ring diffractive array probably. You see the haptics, and you see, give me the push-pull. You see here a slight edge here, and there is a half circle in this part of the lens, and this helps me to align the to identify the back face and the surface of the lens properly to avoid an upside down implantation. If you have an upside down implantation, you have to remove the lens. So again, inverse U shape. Press the optic downwards. Check for incarceration. So again, you see my cartridge is inside the 2mm incision, not inside the eye, but inside the clear corneal incision. I use the second instrument as a leading instrument to help the AddOn lens unfold properly, and then again the positioning underneath. Here it is already. Sometimes you have no haptic primary inside the underneath the iris, sometimes 4. Here you see how easy it was to position the lens, check if every haptic is underneath. Here we are. Sie haben gemerkt, dass das alles ordentlich ging. Ich hatte überhaupt keinen Stress mit Ihnen. Sie hoffentlich mit mir auch nicht. Hat es nicht wehgetan. Sehr gut. Ist alles sehr gut gelaufen. Sehr gut. Ja, das ist von dem... Ja, ich guck's mir. Ja. So. Das ist meistens von mir. Okay. So. Haben Sie noch Lust auf das zweite? Ja. Vielen Dank, ging wirklich alles sehr gut.
A viewer from Serbia says hello. Your experience with patients in which the haptics have been damaged.
If the haptics are what?
If the haptic is damaged or...
damaged, I didn't get it. Yeah, if the haptic is damaged, then you have to make a decision whether to explant the lens or not. If the complete haptic, by the way, I don't know if you agree, but you can damage any haptic of any IOL. And you, of course, can damage the haptic of the basic IOL or the AddOn IOL as well. But there are different kind of damages. If you have a rupture at the basis of the haptic, you have to explant the lens. If you have a slight incarceration at the end of one haptic, and the IOL centers properly, there's normally no need to take it out again.
So from a very simple viewpoint, I would think using two lenses would create worse vision than that obtainable by a trifocal lens.
Yeah, I always have with regard to the question if there's a problem of getting two inside the eye, if a camera company wants to improve the optic quality of a camera system, they put lenses in and don't get lenses out. So we have the experience that with two lenses you have less dysphotopsia and you have less optical side effect, let's say, put it in this way, as with one IOL. Even if we compare the array from the same company, we end up in at least some better results with the two-lens system. Yes.
Do the use of two lenses complicate your calculations for what?
No, it is very easy. If you do it in one procedure like we are doing it today, you make a normal biometry calculation like you always do. Maybe you ask the company to support it, but you take all the calculation, all the formulas you do for the endocapsular lens you want to implant. And then you simply put the second lens on top of it. Yeah, that's it. So if you use two, there's no need to make a different calculation or use a different formula. And if you have a situation where you have a pseudophakic eye, where you have to or want to implant an add-on IOL years after it, you have to do an additional biometry, but the most important thing is a subjective refraction of this eye. This is the leading measurement for the calculation of the add-on situation. Okay, now we do the second eye. Haben Sie Schmerzen rechts?
Nein.
Alles gut. Ja?
So a viewer asks if you would consider as a contraindication a patient who had a prior IOL and has a summer ring.
Yeah, this is a very good question. If you have a summer ring, because probably you have a change of the refractive error due to this, because the summer ring elevates the optic of the IOL, decrease the space between the iris back face and the lens surface, and the A.R.C. as well. So yes, this might be a contraindication. I had one case of a patient with this situation, one or two. In one patient I was able to implant it, in the other not. And I was only able to decide it during the surgery, but I told the patient that is probably going well or not. Because the amount of summering cells was so big that there was no space for a safe implantation of the IOL in the ciliary sulcus. Geradeaus schauen, genau, geht so für Sie? Wasser? Clear corneal incision. Alles okay? Keine Schmerzen? Sehr gut. There was a question about the surgical technique of the nano laser, so I try to show you the chopping technique. the chopping technique of the nanolaser is different as it is in the phaco. I don't make a groove, I make a hole inside and then use it as a place to separate the lens. And then you can easily remove both halves or quarters of the lens. Rotating the angulated opening hole of the nanolaser to reach the left parts of the lens inside the capsular bag. Here we go. Huh?
In your opinion, is the time required for nanolaser surgery the same as phacoemulsification?
Up to lux 3, we end up at nearly the same amount of time. If they are a very hard cataracts, it takes some 3 minutes more or so. But I think if you compare what you are saving and in kind of energy dispersion in the eye, then it's always a very little time you waste. Waste is the wrong expression. It takes some minutes more, let's say. But only in hard cataracts.
In terms of fluidics, are they comparable?
Also in terms, yeah, very comparable. Comparable. Also, if you go up to lux 3, if you end up in lux 4, you need more BSS. But it's also a function of experience, to be honest. If you start doing nanolaser, I would not recommend to start with lux 4. Okay. Again, the AddOn IOL in the Liberty system, the proper alignment of the IOL in the cartridge, folding backwards, avoiding the incarceration of the haptics, slight pressing down. If you hear this clacking noise, if you close the cartridge, then you are on the right side. If you don't have a noise, then you probably have an incarceration of a lens particle. Stabilize your eye, help the lens to unfold. It doesn't matter where the haptics are at this moment. The only thing you have to be crucial about is the fact that the haptics must not be underneath the rexis. Centration. Danke. This is very important for me to check that there's no viscoelastic remnants between both lenses. So, here you go. Yeah. Thank you. So, das war's. Yes.
Does the material of the basis lens?
Yes. The question about the material of the basis IOL, it doesn't matter. It's possible even in old silicon IOLs. If you have a hydrophilic, hydrophobic, I cannot name one company where you are not allowed to implant an add-on in the ciliary sulcus. So even if you don't want to use a basic IOL from the first Q company in combination with the add-on, you could do it. I would not recommend it because the optical systems perfectly fits. But after years, it doesn't matter what kind of IOL is inside the eye. So, after surgery, I would like to focus on some aspects, if you're interested in, of the nano laser, but only briefly. For those who are not familiar with the nano laser, there's no laser light coming out the nano laser tube inside the eye. So there's no need to protect the surgeon or the patient of the laser. There's a nanosecond pulse neodymium YAG laser inside this titanium tube shooting on a target and thereby creating a microplasm and only a small cavitation in the surrounding of the opening hole, which, as you can see here in the graph, is angulated to the side. And this is also the reason why the energy emitted in the eye is even lower than the energy inside the tube. You can see here in high-speed photography that the cavitation, which occurs from the microplasm, is only very small, located around the opening tip. Normally you have, as I said, a minimal energy level inside the tube of 5 to 7 microjoules per pulse, which ends up in an energy applied in the eye even 6 to 9 times lower as measured. And as I also pointed out, you can combine the nano laser to any kind of phaco machine available on the market as long as it got a pneumatic vitrectomy port. This is the combination and the link where you put both systems together, so there's no need to buy a new phaco machine. But this was not the point of today. So to sum all this up is, I think the add-on system, and in this case the Liberty Square, if it comes to the combination of monofocal endocapsular IOL and multifocal add-on, minimizes the risk and maximizes the liberty of the surgeon and the patient to adapt a IOL system to the refractive needs you are facing with. It is reversible. In combination, let's say, with disposable instruments and the nano laser, the whole procedure is 100% single-use cataract surgery. The natural functions of vision in nearly any distance can be restored. So it is a platform to have more satisfied multifocal patients, I think. At the end of the day, where we are now, I would like to thank you for sharing this afternoon with us. It was a great honor to have you all with us. I would also like to thank especially the patients who were willing to be a part of this afternoon. I would like to thank the whole staff who made all this possible. And I would like to thank the First Q company supporting us, the A.R.C company for supporting us. And I hope I could show you live is live, where everything can happen. But it's, I think, the most transparent way to show colleagues who want to see more about this new system, the way how to treat with it. Thank you very much. Take care, have a nice day, and I hope to see you soon, maybe on the same channel. Bye-bye.